And hello, everyone. Good afternoon. And thank you for Living Well for organizing this presentation. I'm very excited today to present to you all about it. And also just wanted to share that coincidentally, today is actually National DNA Day. So there is no better day than today to actually present on this topic. So without further ado, I'm going to discuss with you all today about inheriting cancer and the role that genetics plays. First, I just want to mention that I have no conflicts of interest to disclose. And just some learning objectives are really the agenda for what I had planned for today's presentation. First, I want to start off by just reviewing basic genetic concepts and really the purpose of genetic testing. The second thing that we're going to review is we're going to actually compare the differences between hereditary, familial, and sporadic cancers. I'll then describe two of the most common hereditary cancer syndromes that we see in our clinics. And then I'll explain the role of genetic counseling and genetic testing and really the role that I play with patients when they have questions about their personal or family history and potential risks for hereditary cancer syndromes. So first, let's start off by just doing a brief genetics crash course. I feel that this information is really helpful in guiding our understanding for cancer genetics and even the role that testing and counseling play. So I know this slide may look like a lot, but I'm going to walk you through sort of exactly what it means. Essentially, we are all made up of cells, and that's what that yellow blob is there in the left side. And we're all made up of millions of cells. And within those cells, we have things that are called chromosomes, which are essentially our packages of DNA that make up our genes. And if we were to unravel that package, which is what you can see towards the middle of that visual there. If we were to unravel that package, we would find a long string of DNA that essentially acts as our instruction manual or our blueprint. So it tells us how to look, it tells us how to function, and these instructions are essentially made up of what we call nucleotides, which I like to compare as our DNA alphabet, which compose different genes and create that instruction to code for the proteins that go throughout our body and carry out that specific function that is necessary. So this slide is showing the impact that harmful genetic changes have on those instructions. We actually have a very specific subset of genes with the instruction to actually regulate our cell division or even repair damage that spontaneously occurs. So they essentially protect us from developing cancer. And if there are changes to any of these genes, that impacts how that gene is read, and normal cells can become cancerous. So that's what the image on the left is showing. Normally, our genes are coding the instructions for specific proteins that regulate that cell division. The cells grow, they divide, they make new cells, or they die off if they're too old or damaged. That's the normal process in our bodies. But what the right image is showing is that when there's a harmful genetic change that's causing that gene and then subsequent protein to no longer work properly in our bodies, it's no longer essentially regulating that healthy cell growth. And these cells can continuously lump together to create a tumor over time. I like to typically in my sessions, I'll use this analogy of comparing our genome to a book. And I think that sometimes this is helpful for patients to really understand the genetic concepts that are associated with harmful genetic changes and the role that it plays on our genes. So I always tell patients that chromosomes are like chapters in a book. And the genes are like the sentences in a chapter, and the harmful genetic changes or mutations are like the misspelled words which disrupt the meaning of that sentence, which you can see in this image where it says instead of the car was red, the was red. We're missing that important car word to really interpret what that sentence is meaning. So as you can see from the following examples, we can have various types of genetic changes that alter the meaning of the instruction of that interpretation of a sentence in the book. And whether we're comparing this to reading a book or reading a gene, what genetic testing essentially is doing is reading through those specific genes like we read through a sentence to identify if there's any misspelled words, deleted important words, insertions of extra words, or in this case, insertions of portions of genes that are causing our bodies to no longer interpret that instruction of that gene. So this leads into what is genetic testing. And the Genetics Home Reference actually describes it as a medical test that identifies changes in chromosomes, genes, or proteins that can confirm or can rule out a suspected genetic condition, or can help determine the chance of developing or passing on a genetic disorder for family members. I always like to clarify with my patients that having a genetic change in a gene does not mean that you will develop cancer or have cancer, but it means that you're at that increased risk. So when we identify genetic changes in patients, we can help them alter their surveillance or their management to be more proactive or even reduce the risks of certain cancers developing. Lastly, genetic testing should be voluntary. So we have consults with patients actually to provide them with all the necessary information to move forward with an informed decision on whether or not genetic testing is something that they want to do, whether or not it's appropriate for them and their family history as well. The next section that I want to briefly review is the differences between hereditary cancer, familial cancer, and sporadic cancer. So one statistic that I have found that shocks a lot of my patients is that only 5 to 10% of the time cancer is hereditary. So that's that small percentage on that piece of the pie. And what that means is that there's a harmful genetic change that's inherited with each generation, causing significantly increased risks for cancers in certain family members. The majority of cancer is actually sporadic. So cancer that's just caused by chance, that can be caused by lifestyle, environment factors, and that's why there are general population cancer risks. So I share with patients that 1 out of 8 women will develop breast cancer at some point in their lifetime just due to chance. So that's about 12.5%. And we have those general population screenings that are put in place for women because of those sporadic risks. So the mammograms that women typically have. And then familial cancers are cancers that we see clustering on one side of the family, but it's more so due to a shared lifestyle or a shared environmental factor. So for these cases, I always, share with patients that even if testing is negative or normal, there still could be a familial factor or something that we can't quite pinpoint that's causing cancers to cluster on one side of the family, whether that's lifestyle habits or environmental factors. And what genetic testing is doing is essentially ruling in ruling in or ruling out that 5 to 10% of hereditary cancer. And if we identify a harmful genetic change, what cancer risks those patients may have or additional cancer risks, and how we can change their management to be more proactive, catch cancer at its earliest, most treatable stage, prevent it from happening, or reduce those risks, or even assist with surgical decision making for some patients. So now I'm going to review examples of some of the common hereditary cancer syndromes that we see. Here I'm going to talk about 2 of the most common that we see and the genes that cause them. However, there are many other examples of hereditary cancer syndromes that we are often evaluating for with other features or associated cancer risks. Before we jump into that, I just want to review some of the characteristics of hereditary cancer, or some of the red flags that we're typically looking for in family histories or even personal histories. So, some of these general features suggestive of a hereditary cancer syndrome include cancers diagnosed at unusually young ages, so typically under the age of 50. Unusual cases of more rare types of cancers like male breast cancer, pancreatic, ovarian, or even cancers that have developed in both organs of a set of paired organs. So, like both breasts, both kidneys. And even having several close blood relatives, so first, second, or third degree relatives that have the same type of cancer, multiple generations affected with cancer, or even an individual with a personal history of multiple cancers as well. So these are some of those typical red flags or characteristics of hereditary cancer that I'm looking for in a personal or family history. So the first hereditary cancer syndrome I want to talk about is hereditary breast and ovarian cancer. This is caused by harmful genetic changes in the BRCA1 and BRCA2 genes, which are tumor suppressor genes, which essentially are a type of gene that regulate that cell growth. So when a tumor suppressor gene has a harmful genetic change, uncontrolled cell growth may occur, which potentially could contribute to the risks or increased risks for certain types of cancers. So we all have the BRCA genes in our bodies. It's just whether or not there's a harmful genetic change that's causing it to not work properly in our bodies or regulate that cell growth. You may recognize the names of these genes just due to potentially hearing them in the media, or you may be familiar with Angelina Jolie, who was a famous actress that made headlines many years ago with her testing for these two genes due to a family history of cancer. And she had made the decision at that time to reduce her risks of developing cancer by moving forward with some prophylactic surgeries. And that was based off of the result of her genetic testing. So I'm going to review the typical cancer risks that are associated with harmful genetic changes in these two genes and the lifetime risk using the age of 80 to develop those cancers. For these increased cancer risks, there are surveillance and management recommendations that are put in place to help these patients and their care teams to be more proactive and follow them more closely. So first, I want to talk about the increased risks for breast and ovarian, as there is a significant increased risk for these in females or individuals that are assigned female at birth. For those unaffected by cancer, this increased risk for breast cancer can warrant high-risk breast screening protocols, which typically is like having mammograms and alternating breast MRIs that typically begin at earlier ages. Alternatively, there are also risk-reducing options like prophylactic surgeries by removing the breast tissue or the ovaries to also reduce the risks of developing those cancers. For males, there is a slight increased risk for male breast cancer and prostate cancer. And we do discuss the surveillance options that are available for males as well, which may look like starting prostate screening earlier or having clinical chest wall exams for their risks for breast cancer as well. And males can also consider having mammograms too. There's also an elevated risk for pancreatic and melanoma. Pancreatic cancer, typically the screening is based off of a family history. And then for melanoma, there are no formal guidelines in place for these patients, but we do recommend, protecting your skin from the sun, reducing UV exposure, visiting with a dermatologist for skin exams, things like that. For individuals that are affected with cancer, the identification of a harmful genetic change in one of these genes can oftentimes help inform surgical decisions during their ongoing diagnosis and treatment, or potentially even inform whether they are candidates for certain targeted treatments that are available. And to further explain and clarify, I want to also mention again that for even unaffected, patients that have this testing done, it doesn't mean that you will develop cancer or have that cancer. It just means that you're at that increased risk. So these are some of those protocols and management recommendations that we put in place for those patients, so that we are following them more closely and helping them be as proactive as possible. Listed here are some of the risk factors that we typically evaluate for patients to determine if genetic testing is appropriate based off of their personal or family history. So patients that typically meet criteria for genetic testing are those that have a personal history of triple negative or metastatic breast cancer, personal history or family history of ovarian cancer or pancreatic cancer, or cancer that's diagnosed under the age of 50, a personal or family history of metastatic prostate cancer, or having 3 or more close relatives with breast, ovarian, prostate, or pancreatic. In addition, there are, for those that have Ashkenazi Jewish ancestry, 1 out of 40 individuals we know potentially could have a genetic change in one of these genes. So having that type of ancestry can also be an indicator for genetic testing. All right, and then I talk a lot about BRCA1 and BRCA2, but there are many other genes like BRCA1 and BRCA2 that play a role in the risks for breast cancer. So that's what this slide is showing, and the various genes that we know of that have the risks for breast cancer. The cancer risks and the management recommendations are all gene dependent. So there are more high risk genes, and then there are more moderate risk genes. And in addition, the different types of cancers can differ based off of the gene as well. So the management recommendations and surveillance recommendations are all very gene dependent and may vary depending on the genetic variant that is identified in a patient. For those that underwent testing for only BRCA1 and BRCA2 potentially years ago, current guidelines do recommend updated genetic testing to look at these additional genes to determine if there was any other hereditary cause for developing cancer. The next hereditary cancer syndrome I want to talk about is in relation to hereditary colon cancer. So colorectal cancer is the 3rd most diagnosed cancer in both men and women. And typically colonoscopies are recommended to start at the age of 45 in the absence of family history, and to occur every 10 years if normal. However, the presence of a known hereditary cancer syndrome can change how frequent that screening is occurring. So Lynch syndrome is the most common hereditary cause of colon cancer. It's also known as hereditary nonpolyposis colorectal cancer. And it is caused by a harmful genetic change in one of 5 different genes, which I have listed on the screen. These are genes that are associated with a process in our body called mismatch repair. So when these MMR genes repair, so typically they repair spontaneous errors that occur during replication, and when there's a harmful genetic change in one of these genes, they don't function as properly, and that can lead to the development of cancer. For the cancer risk, so I have the typical cancers that are associated with Lynch syndrome. The highest cancer risks, and I should say that the 5 different genes that are typically associated with Lynch syndrome, they all have varying different cancer risks associated with them. So that's what this image is trying to show. But the highest cancer risks are typically associated with colon cancer for both males and females, and then uterine cancer for females. So To give an example of how management changes for these patients, typically colon cancer, we change that frequency of colonoscopies from every 10 years, potentially to every 1 to 2 years, to screen more frequently for that cancer, remove colon polyps if identified. And then for females, there's an increased risk for uterine and ovarian cancer. And so for these cancers in females, we typically recommend making sure that they're educated on the importance of any prompt reporting of symptoms that they may be experiencing, whether that may be abnormal bleeding, postmenopausal bleeding for uterine cancer risks, or even pelvic pain and other symptoms that can be associated with ovarian cancer. Alternatively, women that have a harmful genetic change in one of these genes can also consider having the uterus and ovaries removed to reduce the risks of these cancers as well. And then beyond colon and endometrial or ovarian cancers, when it comes to Lynch syndrome, there are other cancers that are associated, and that's shown on the figure as well. And different screenings may be recommended or may be made available for those patients, like having upper GI surveillance, earlier prostate screening, or baseline pancreatic screening if appropriate. Some of the risk factors that I have listed here are associated with Lynch syndrome. The first risk factor is having abnormal tumor screening for Lynch syndrome, which is typically done by IHC or MSI screening. And this is typically a routine screening that's done on colon or uterine tumors. And so if it's abnormal, typically those patients should be referred for additional genetic testing. Other risk factors may be having personal history or family history of colon or endometrial cancer that's diagnosed under the age of 50, or having a family history of 3 or more close relatives with the cancers that I have listed on the screen. When we do testing, I like to make sure that my patients are aware of the 3 types of results that we can expect back. So those 3 types of results are positive, negative, or uncertain. With positive results, we've kind of talked about how that can inform those increased cancer risks or those management or surveillance recommendations. But one thing we haven't touched on is how this information is inherited to other family members. So for positive results, most hereditary cancer syndromes follow what we call an autosomal dominant inheritance pattern. So that essentially means that there's a 50% chance that first degree relatives, children, siblings, parents have or inherited that same genetic change and may be at risk. So we help patients navigate these conversations with family members and also assist them with finding genetic counselors local to them to obtain that known family variant testing. The second test result that we can expect back from patients is negative testing or a negative result. So that essentially means that of all the genes that we tested, there were no variants of clinical significance that were identified. So negative results, they never eliminate risks for cancer. We still follow regular screenings, and for family members, we always recommend that they are sharing their family history with their doctors. And there's always the possibility of a yet to be identified gene that wasn't included on today's testing or technology. So genetics is constantly evolving, and we're always learning more and potentially adding more genes onto panels as we find out about their association with cancer risks. The third type of result that we can expect back from testing is what we call a variant of uncertain significance. So a variant of uncertain significance essentially is a genetic change that right now we don't have enough evidence towards. Is it something that is, something that's causing a risk for cancer and is pathogenic, or is it something that is benign and potentially just part of normal human variation? The labs that we work through, they are, continuously learning about these uncertain findings, and they do reach out to us if we ever do learn more about them so that we can contact our patients to inform them. But typically with uncertain findings, we do treat them as negative or normal until we know more about those results. So we don't typically test other family members for them, and we don't typically change the management of our patients when uncertain findings are identified. But it is something that is common on test reports, so it's always good to be aware of that type of result that can be identified. So now I'm going to touch on the role of genetic counseling and genetic testing today. So, with genetic counseling essentially is the process of helping people understand and adapt to the medical, psychological, and even family implications of genetic contributions to disease. This process is typically assisted by having a genetic counselor assist with that consult, and are individuals with specialized education in genetics and counseling to provide that personalized help for patients that may need it as they make decisions about their genetic health. The link that I also have on the screen, findageneticcounselor.com, is a great resource to find a genetic counselor that is local to you or even to family members that may be seeking this information. Some of the reasons to see a genetic counselor. This is kind of a recap of some of the information that I've already shared, but prevention, diagnosis, and treatment. So patients can learn of ways to prevent disease or reduce or lower their risks for cancer. This may include additional screening, medications, surgical interventions. For a diagnosis, it can help with discovering an explanation or an underlying cause for certain medical issues, or even identifying potentially a cause for the cancer in the family. And then for treatment, personalized treatment and tailored care. That is one of the benefits of testing. And in cancer, this may look like having targeted therapies or more personalized surgical recommendations based off of the genetic test result. So I wanted to share a little bit about what to expect from a genetic counseling appointment. So this slide is helpful for patients to understand, the different things that we typically talk about during these sessions and how to be prepared. So the first thing that we typically do in these sessions is we review our patients, their personal health history, if they have a recent diagnosis, any ongoing treatments or related care. And we also draw out their family history on both sides, so the maternal and paternal side. And I always recommend that patients come prepared with this information, just because it is helpful in guiding any testing options that we can offer, and even looking for some of those characteristics of hereditary cancer in the family. We then will do a brief genetics education, similar to the beginning of today's conversation, actually, and discuss the medical, emotional, psychosocial implications of genetic testing. So even talking about how this information can potentially affect them or even their families. The next thing that we do is review testing options for patients. So there are various different gene panels that can be appropriate for patients, and we help them with that informed decision making. So figuring out which testing is most appropriate and right for them. Once we order that genetic testing, it can be done through either a blood draw or even a saliva or a buccal sample. Results typically take 2 to 3 weeks to come back to us. And once results are returned, we review with the patient and also collaborate with their healthcare team to ensure that they're being followed appropriately. We also make sure to provide patients with the resources and the additional support to help navigate this new information or even share with family members. This is just showing the process of meeting for patients to meet with a genetic counselor, which typically begins with that referral, whether that's coming from your primary care provider or your oncology team. The patient then meets with us for that pre-test counseling. We order the testing, and then we provide that post-test counseling after results are returned. And we also initiate the appropriate follow-up for patients depending on the results. So this may include encouraging patients to share info with their family members. And if family members come in, they navigate through this same process or same cycle as well. Genetics has evolved a lot over time. So I kind of wanted to talk about some of the advancements that we've had in genetic testing today. That includes that there are many different genetic testing laboratories and genetic testing that's available for patients depending on, what is appropriate for what testing needs to be ordered, what their personal history or family history looks like. Tests have become more efficient and have become more accessible for patients. There's also more and more insurance companies that are beginning to cover the genetic testing. And legal protections are also available for patients to, so there's certain laws that are put in place that actually help protect patients from health insurance companies or employers from using any of this information against them. And then our understanding in genetics is continuously improving and growing exponentially. So we're always learning more and adding on to the information that we have, following up with patients if there's been updates in management or surveillance recommendations. So it's continuously growing and we're always learning more. In the future, what we expect in the future is that genetic testing will be an important part of healthcare for many individuals. We also hope that the cost of genetic testing will continue to decline and continuously be more accessible for patients, and that genetic testing will also help deliver a more personalized and more precise medicine for patients. So whether that's detecting disease risk, offering more accurate diagnoses, guiding treatment, maintaining health, those are some of the hopes that we have for the future with genetic testing. So with that, I hope many of you found this session to be informative and helpful in many ways. I have listed here some of the genetic counselors that are in the West region, specifically with Northwestern, and the different genetic counseling specialties that some of our genetic counselors specialize in. So we've got cancer, prenatal, pediatric, and adult. I primarily am a cancer genetic counselor. And then I've also listed out the locations for cancer genetic counselors for me and then my colleagues as well. So the Delnor Cancer Center, Warrenville Cancer Center, and Kishwaukee as well. And I also wanted to mention that if you found yourself relating to any of the characteristics or risk factors associated with hereditary cancer syndromes, I encourage you to reach out to your doctors for a referral, to meet with a genetic counselor who can help navigate a lot of those questions or even review, your hereditary cancer risks. So please reach out to your referring providers if that is something that you are interested in or that you found that could be helpful for you.